welcome to our evening for management and prevention of injury to the knee while skiing. I'm Fiona Roach. I'm the Business Development Manager here at the Sports Surgery Clinic. Any of you that don't know us or have never been here, we're about 10 minutes from Dublin Airport. We're just off the M50 of the M1 in Santry in Dublin. So we treat all things orthopaedic, musculoskeletal injuries and diseases like arthritis. So we look after all your joints from the neck down to your toe, hips, knees, fingers, everything. Now we have 7 theatres, we have 130 beds. So there's 3 MRI scanners now, 1 CT, with a state-of-the-art physiotherapy department and sports medicine department. So tonight we've got 2 speakers. We've got Andrew Kavanagh from physiotherapy. Andrew's going to look at rehabilitation of the knee. And then Professor Brian Devitt, who's one of our knee surgeons here, is then going to also talk about knee injuries and what happens when you're on the slopes. So Andrew's going to start with his presentation and he will join us then live for Q&A. So you'll see a tab there at the bottom. If you press that, if you want to ask a question, just keep typing them in and we'll endeavour to answer all of your questions tonight. There's another tab there if you want to make an appointment or have any further things you'd like to ask further on. And then for future events also. Now, we do events like this all the time for different sports, different parts of the body, and they're all on our website if you want to go back in and look at those. And if you know anyone that's missed this tonight, they can also do that as well. And this one will be up on the website as well. So thank you for joining us. And we're going to start now with the presentation from Andrew. Thank you.
Hello, my name is Andrew Gilsenan-Kavanagh, and I'm a sports physiotherapist here in the Sports Medicine Department of the Sports Surgery Clinic. Thank you for joining us this evening on the information evening. We're going to centre this talk around common rehabilitation of ski-related knee injuries. So I'll start by talking about some of the demands on the body, some of the benefits of skiing, touch on some of the injury rates, then we'll talk through a little bit of anatomy of the knee, the most common knee injuries, some injury prevention methods, rehabilitation of some of these more common injuries, exercise demonstrations, and then we'll have time for the live questions on the night as well. So now we'll talk about demands on the body. Skiing can be classed as an extreme sport, and for good reason too. It has a mix of endurance and resistance training combined together. It's taxing on the lower limb muscles. It increases our heart rate and respiratory rate. Uses muscle groups not commonly used. We have to deal with sub-zero temperatures. And obviously, the more advanced skiing we do, the more demanding it is on the body. Along with some of the demands on the body, we also have huge benefits to skiing. So it's an excellent form of exercise. And we as physiotherapists are always trying to advocate the use of exercise and the use of strength training. And this combines the two of them together. It boosts our mood. It strengthens the lower limb muscles. It improves our flexibility. And it also engages the core muscles, as we need a strong core as we continue to ski, particularly on more difficult slopes and at higher speeds. So let's talk about skiing and some of our injury rates. So luckily it's a low injury rate for a high risk sport. The knee is the single most common affected joint in skiing. 35% of all of these injuries occur at the knee joint. And the medial collateral ligament, or the ligament running along the inside of the knee, is the most common injury. So here we have a diagram of a knee, and we're just going to touch on some of the anatomy or some of the structures, ligaments, tendons, centered around the knee. The most common ones that we'll talk about today are the meniscus that we can see here between the 2 bones that are big shock absorbers. We can see a ligament running along the inside of the knee here, which is our medial collateral ligament, or MCL for short. And then we can also see the anterior cruciate ligament, or ACL, which there has been much research about of late, and most people will be familiar with the anterior cruciate ligament. So let's talk about these most common injuries. So as we discuss the MCL, or the medial collateral ligament, this is the most common injury. So a sprain or a tear in this ligament. The anterior cruciate ligament is the next most common, and again we can have sprains, which is a more minor injury, or a tear, complete rupture. And then we also have meniscal injuries, which are the shock absorbers in the knee that can be injured from skiing related falls. So medial collateral ligament injury. As discussed earlier, this is the most common injured ligament in the knee while skiing. Typical injury from this can result from a blow from upslope on the outside of the knee. So we can see here in the diagram, there's a direction of force coming from the outside of the knee, which is pushing the knee inwards. In turn, this will stress the ligament or strap-like ligament along the inside of the knee, which can cause either a sprain, which is a stretch, or a tear or complete rupture, which is when the ligament is severed. Following an injury like this, we can have some perhaps delayed swelling, immediate pain, depending on the severity of the injury, and a sense that the knee is unstable or inability to weight bear through the knee. The second ligamentous injury then is the anterior cruciate ligament. So this injury typically is a more forceful injury. When we have some rotation of the knee, with a ski getting caught, perhaps landing awkwardly from a jump. Typically with a complete tear of the anterior cruciate ligament, we will hear either a pop or a snap, and we will have some immediate pain and immediate swelling with this. Again, inability to weight bear can be a sign of a higher grade injury. And finally, we have our meniscal tear injury. So in this diagram, we can see a picture of the meniscus from a frontal view of the knee. We can see this is the shock absorber that's sandwiched between the big bones in the knee. And on the right-hand side of the screen, we can see a tear in the meniscus. These injuries can typically occur from some sort of rotational based injury. So this can be an awkward fall, it can be a ski getting caught, or it can be from a trauma from an upslope collision. Some of the telltale signs of these type of injuries are symptoms that disappear as we straighten out the knee and that reappear as we bend the knee. This is as we compress that shock absorber when the two bones come together. And now we'll move on to factors that lead to knee injuries. So level of ability, skiing at a level that is too fast or too steep for our ability can inevitably cause injuries. Another point is incorrect, ill-fitting or damaged ski equipment. Perhaps boots that are too loose, ski bindings that are not adjusted to our weight and come off while we're skiing at speed can all cause injuries. Our fitness levels and strength levels, and we will touch on our strength levels as we move on through this presentation. As with any sport, taking too many risks, and ski conditions can have a big part to play when we talk about skiing injuries. So now we'll move on to reducing the risk of sustaining a potential injury. So we touched on strength in a previous slide, and now we're going to look at some targets, some things that perhaps you at home can aim for to see how strong is strong enough. So for our front squat, we're looking for 50 to 75% of our body weight. And we can see that in the bottom corner of our picture here. Wall sits, again, we will see them later on in the presentation. We're looking for 4 sets of a 1-minute hold. And leg press, we're looking for 1.2 to twice body weight. For our posterior chain then, for our big bum muscles and hamstrings, we're looking at our deadlift, which we're looking for at least a body weight lift on this. Our hip thrusts, again, this should be our strongest exercise. So we should be aiming for 1 to 1.5 times body weight on this exercise. Then if we talk about our upper body, so a consecutive round of 10 to 12 push-ups can be a measure used here. 1 to 3 pull-ups, or a single arm row where we're pulling at least 30 to 40% of our body weight. Now these are quite general targets, which can be used in the general population. As we progress into maybe more athletic or more elite ski teams, we're looking for higher levels of strength. So now we'll move on to our initial injury management. So if we're unlucky enough to pick up an injury like this, what should we do? In the first instance, we need to stop skiing. We need to use the police method for swelling management. So some of you at home may be familiar with this method, previously known as the Rice method. We'll talk through it now. So protection is the first thing. So again, we want to remove ourselves and rest ourselves up. So that's taking a break from the slopes. Optimal loading. So this is more our rehab-based stuff, which we will talk about later in the presentation. Ice, compression, and elevation. These are going to be our big 3 to try and manage that swelling and manage that pain early on. Again, we reassess this after 24 hours. Initial swelling and pain should start to subside pretty significantly if we're using this method after 24 hours. However, if we're struggling to get the pain and swelling under control, it's a good idea to seek some medical professional in the locality of the ski resort. So then you've returned from your ski holiday, you've come back. What are the urgent signs and what are the non-urgent signs that we need to see our physiotherapist? So again, that pain and swelling, that persistent high levels of pain and swelling which hasn't subsided, inability to weight bear, particularly a day or two after the injury, and a knee locked in a certain position. So we discussed earlier with the meniscal tears, when we're straightening and bending our knee, sometimes those symptoms can reappear and then sometimes they can subside. So particularly with our meniscal injury, sometimes the knee can get locked in a certain position and we can struggle to straighten or bend this. Some of the non-urgent signs, if we're struggling to get back to full function, so we just feel like this injury is lingering, we're able to manage on a daily basis, but perhaps we can't get back to more higher level tasks. Unable to regain full movement in the knee, so perhaps we're struggling to fully straighten out the knee or fully bend the knee, and a decrease in strength and endurance. So let's move on to some rehabilitation or rehab ideas for some of these more common injuries. So here in the sports surgery clinic, we use a 6-step approach. So we move from our diagnosis and assessment. So if you come in first from a ski injury or from a ski holiday, first of all, we want to get a diagnosis and get a good assessment, strength back to normal levels. Thirdly, then, once we have our strength in order, we want to build on top of our power and our reactive strength, particularly some people who are maybe going back to high-level sport or back to high-level skiing. Then we bring in our linear running and our multi-directional running, and then we're back into sport-specific and fatigability. And this is the end stage before we go back to performance. And now we're going to move on to some rehab ideas and some rehab exercises for the more common knee injuries. So here you can see my colleague, Vanessa, who's performing a wall sit exercise. So we're going to start off with a double leg wall sit, 90-degree position at our knees, flat back flat against the wall. We're aiming to hold this position for 20 seconds by 4 sets. A progression of this can be moving on to one leg and holding for the same amount of time. Next, we have a leg extension exercise. So we can see Vanessa here doing a single leg extension, which could be completed in a normal gym. We're straightening out the leg, keeping the toe pulled up towards the sky, all the way up and slowly back down. So slow and controlled with this motion. Again, aiming for somewhere between 3 sets of 8 and 3 sets of 10. Here we have our pistol squat exercise. So we can do this in a gym or using a banister at home, something that we can hold on to. Having a chair behind us around knee height. We're going to slowly lower ourselves down on to touch the chair and then come slowly back up. The key to this is that our knee doesn't drive out over our toes, and we're trying to maintain our knee in the same position. And finally, we're going to move on to our crab band exercise. So the previous 3 exercises, we focused on the quad muscle along the front of the leg. Again, after knee injuries, our quad muscle is the most affected muscle. So inevitably, we're going to be decreasing our strength in this muscle. So it's vitally important that we work hard to build that strength up to the same strength as the other side. Another important muscle following an injury like this is our lateral hip muscle along the side of our bum. So here we can see Vanessa performing a crab band exercise. So we have our feet hip distance apart, we have a black band just up above the knees. We're going to sit back into this. We're trying to keep our feet flat along the floor, and we're going to push our knees apart, hold for 3 seconds and come back to the start position. Again, this can be done in a gym or it can be done at home using a banister or a door frame. So these are the main exercises that I would focus on post-injury after skiing. But also these can be used as prehabilitation or before we go skiing to build up the muscles around the side of the hip and the muscles around the leg. So that concludes today's presentation on knee injuries and skiing. Feel free to ask any questions in the live Q&A after this presentation. And if you want a more individualized approach, book in to see a physiotherapist or an SSC coach at sports medicine at a time that suits yourself. Thank you.
Andrew, thanks very much for that great talk and joining us tonight. And we've also got Professor Brian Devitt with us as well. He's going to answer some questions now, and then we're going to come back after Brian's talk and answer some more questions. So I'll start with the first question for tonight. Andrew, I've osteoarthritis in both knees. Would that prevent me from taking up skiing? And are there exercises I can do to prepare for that?
Sure. So I suppose there's a couple of arms to the answer on that question. The easy answer would be no. You can certainly ski with arthritic knees, absolutely. Are there things that can help you? Absolutely, yeah. So some of the videos that we touched on in the presentation focused around quad strength and lateral hip strengthening. The stronger we are in these areas, the more pressure will take off the knee, and the easier skiing is going to be for us. Now, I suppose age will come into this, the age of the patient who's skiing or the person who's skiing, and the level that they want to get back to. So obviously, the more intense or the more higher level skiing, the harder it's going to be if there's a high level of arthritis, if there's a lot of arthritis in the knee. But as an off the bat answer, I'd say absolutely not. You can certainly ski with arthritis in the knee. Yeah.
Okay. Brian, I think actually a few people have asked that question tonight. There's someone else that said, should they avoid skiing totally with arthritis? But basically you're saying no. And Brian, any comment on that one?
No, I think, within moderation as well, I think you have to look at the period of time you're going to ski for. It's a fairly active exercise, puts a lot of pressure on the front of the knee. So one would try to be a bit judicious how long you spend on the slopes, and perhaps have a few anti-inflammatories ready with you on your trip, just in case you do get a bit sore. But certainly, I went skiing a couple of weeks ago with my mother, who's some arthritis in her knees, and I was chasing her down the slope. So I don't think it's a contraindication whatsoever.
Right, okay. So another one here, Brian. Due to wear and tear, I had a full knee replacement 12 months ago. Should I be expected to be able to ski?
Yeah, and I think, that's once again using Andrew's kind of answer, same with arthritis. I think it depends on what level you're skiing at and how much you want to ski and the degree of difficulty of the slopes. But certainly there's no reason why someone can't go back to skiing following a knee replacement. I think once again, you want to maintain your level of fitness and the same muscle groups, the quadriceps, your gluteal muscles. You need to be fit and active to be able to do so. And I would suggest if one is going back that they don't go on a black slope to begin with and start relatively easily and just have reasonable expectations. But Andrew might want to offer some other advice from a physiotherapy perspective.
Okay. Andrew?
Yeah, sure. So yeah, I think a lot of that comes down, we see a lot of patients post-operatively here from a rehab point of view, haven't had a knee replacement with Brian or some of his colleagues. And I think it comes down to, the level of rehab and what they want to get back to. So what the patient puts into it, they kind of get out of it, so the higher level they want to get into, the more intense rehab is going to be involved. But, as Brian says, I think it's certainly achievable, but just having your goals and ambitions in line with that,
Yeah, actually someone else just came in with the same. Someone said she's a very frequent skier, just over a knee replacement and hoping to ski next year. Is this realistic? So you kind of answered her question as well on that one. Right, we have a few ACL ones here now. So what is the usual time for returning to sport after an ACL injury or tear? So, and skiing as well, I suppose, particularly.
Yeah.
So sorry, Brian.
So I think we've probably changed our outlook on that over the last number of years, because we recognize that the most vulnerable time for someone to re-injure is within the first year after ACL reconstruction. So we tended to push back the time a little bit in terms of they're looking at anywhere between 9 months and 12 months typically now. But we're a little bit more objective about that as well. I think that the advantage within the sports medicine department is we do ACL testing. So we look at an individual's strengths compared to their other leg, and also look at their ability to perform tasks. So Andrew or his colleagues would do a full battery of tests to see how someone is coping after an ACL reconstruction. But typically it's in the region of around 9 to 12 months. We look to return to sport, all going well.
Okay, someone's actually asked as well about, they had ACL surgery actually just in October. They suffered a hematoma at the time as well, and which is bleeding into the leg. And the consultant has given them the all clear, but they wanted to know, would they be fit to go by the end of March?
I don't know about you, Andrew, but I think that's a little bit too soon from my perspective. But you'd have to assess the individual. But Yeah, I'd be a little bit concerned to go in March. I think perhaps next year, or go to the Southern Hemisphere to ski in late June or July elsewhere. But I think that's a little bit premature personally.
Okay. So Elaine, she fully tore her ACL, almost fully tore her MCL, bone bruising, small fracture. How soon should she see a consultant? She's in a brace and it happened on the 2nd of January. So
from my perspective, I think, a reasonably acute consultation, so within the next couple of weeks, I would think be appropriate. But more importantly as well, I think that you need to get to see a physiotherapist to get moving that leg. I think one of the fears we have when someone's had an injury of that nature is that they don't move and get stiff. And that's a really important, and maybe Andrew could give his opinion regarding the effect of the importance of range of motion pre-operatively.
Yeah, absolutely. So we see a lot of these what we call pre-op ACLs, and the first thing they come in on crutches, perhaps in a brace, very fearful of moving the knee, very fearful of putting weight through the knee. And if a patient of moving like that was to go straight for surgery, I think they'd be in a little bit of trouble. So what we want to do is reassure the patient that we want to get the knee moving, bending and straightening within normal ranges. We want to get the quad muscle on the front of the leg working adequately, and then get them into surgery. So it's kind of a case of the better condition they are going into the surgery with yourself, Brian, the better condition they are going to be coming out of it, So I think that's quite an important factor as well, especially particularly with the ACLs and the younger athletes who are more fearful.
Yeah.
Okay, good, thanks. Patient hoping to ski regularly twice a year, but have ACL damage in both knees, not ski related. One has been repaired with a graft and the other one hasn't had surgery, just rehab about 5 years ago. Any advice, this is for Andrew, on strengthening exercises or preventative measures, example supports to help prep while skiing?
Yeah, absolutely. So I think as a general answer to this question, there absolutely is. And when we're talking about general strengthening advice for ACLs, a lot of it is going to come centered around the gluteal muscles and the quadricep muscles. It's going to come from a strength point of view and also from a control point of view. So how well can we control that muscle as we're moving, perhaps in a single leg squat motion, something of that nature. But for something like that, it's very hard to give individual advice on a query like that. Yeah. Ideally, we'd like to perform some sort of testing so we can have some kind of objective data to fall back on, and then give them more of a concrete answer on
that. Someone's just said, I think probably from your video, said, would the band crab exercise irritate the meniscus or the menisci?
No, it depends on what the degree of meniscal injury is. So if it's what we call a displaced meniscal tear, maybe where a piece of the meniscus has come out and is causing irritation in the knee, something where the knee is perhaps locking, that may be something that might have to be surgically excised or just removed. But other than that, the exercise can be adapted so that we wouldn't irritate the meniscus. Yeah.
Okay. Someone's actually asked, does skiing increase the likelihood of developing osteoarthritis?
I'm not aware of any studies that have shown it. I think, if you rupture your ACL, unfortunately, the risk of developing arthritis is greater, and skiing is a high risk sport for ACL injury.
Yeah.
Typically, skiing, skiing is you're downhill. It's you're just a bending motion within your knee. Normally, if you ski well, so unless you get injured, I wouldn't think it would increase it significantly. But if you're injured, perhaps it does.
Yeah. This one for you, Brian. Sustained a tibial fracture, left knee, no displacement on Christmas Day in France. Home last week and have been referred to a local hospital for the fracture clinic, but hasn't been seen yet. Still in a knee brace and on crutches. When should I start physio and be fit to return to skiing? Well,
I think the important part of that last question is when should you start physio? I would say immediately. I think that the likelihood is this brace may not be a brace that moves, and that can be problematic given that it's almost 4 weeks now since the injury. So I'd certainly see a physiotherapist and likely get to see an orthopedic surgeon reasonably soon to get moving. I would hesitate to answer the latter part of that question without assessing the patient.
Okay. I tore my ACL skiing 2 weeks ago, but waiting an MRI result before seeing a consultant. Do you recommend the physio demonstrated in the video to do at this stage? So Andrew, that's one for you.
Yeah. So absolutely. This is what we call, it would fall into the category of a preoperative physiotherapy for ACL.
Yeah.
The exercises and the muscle groups that we're working in the videos would absolutely be appropriate, but it's just the dosage is really important, and that's why it's kind of important to see a physio maybe to get a tailored program to make sure that the exercise is at the correct level for the patient. So some of those exercises, particularly a single
scenario, but if they improve in their strength or they adjust the strength deficit, there's no reason that that person couldn't ski. But they'd want to be able to kind of move or perform, reasonably good twisting exercises prior to considering it. And blue slopes are probably one of the more dangerous slopes. They tend to run into the village and where lots of people congregate. So that might be the easiest one to go for.
Okay. Right, we're going to show your presentation now, Brian, and both of you will join me afterwards for some more question and answers. Thank you.
Thank you.
Good evening, ladies and gentlemen. I'm going to speak this evening on common knee problems when skiing. So the title of my presentation is Beware the Slippery Slope. My name is Brian Devitt. I'm Professor of Orthopaedics at Dublin City University and a consultant orthopaedic surgeon at the Sports Surgery Clinic. So this is a common scenario when we're skiing. So if you've friends like those, who needs enemies? You're right. So I'm just going to replay this video clip in slow motion, and you just see how a common knee injury can occur. So he's going through a very deep snow, and he has a slip back. And that crack you hear is not his ski coming off, but his ACL rupturing. So unfortunately, knees and skis, ACL injuries are very common bedfellows. I did one of my fellowships in Vail, Colorado, which is a ski resort, and it's essentially a conveyor belt for knee injuries. And one of the forefathers of ski treatment in terms of knee injuries is this gentleman called Dr. Richard Stedman. And he told me when I was there that if you were to design a device to rupture the ACL, you couldn't get much better than a ski. Now, skiing is good for business in ACL surgery, and that's why they have a big hospital at the foot of the ski hills. And the reason it's good is that skiing has become hugely popular. It used to be just a sport for the wealthy, but now most people have access, at least can go skiing once in their lives, but many people go a couple of times a season. But it's a risky sport. And we look here at some of the statistics of which joints get injured. You see that the upper limb happens in 17% of cases. You get forearm or hand injury in 7% of cases. You can get some neck or back pain less commonly, but then you get an awful lot of knee injuries, which represents up to 35% of injuries. And these relate to the ski and the devices the equipment you use for skis. So if you think back to the olden days when people used to strap themselves in their boots to 2 wooden planks and go down a mountain, things have advanced quite a lot with respect to knee injuries and equipment and skiing equipment. We have a boot that's fixed, and the boot allows a little movement at the ankle, but it's fixed to the ski. And unfortunately, when the ankle is fixed, that all the rotation occurs around the knee, and that's where you get a lot of injuries. The skis themselves have improved, and you look at the binding of the ski, and this allows the boot to come out. So when you're going to a ski to get fitted for skis, they'll often ask you your level of expertise, being novice, advanced, or expert. And really what they're doing in this scenario is they're tightening your boot, or the din, they call it, to the extent to which you have to move or pivot for your boots to come out of your skis. So expert skiers have their boots fixed into the skis, and therefore, if there's any twisting, it goes through the knee and the boot doesn't come out. So if you're anyway apprehensive when you're going to get your skis fitted, ask them to keep the din low so your boots can come out of the skis and not your ACL rupturing in your knee. We also recognize that terrain and the conditions are very important for knee injuries. And obviously steeper slopes or heavier snow or slushier snow can be developing injuries. We also know that skiing is often, the après ski is quite popular. And it's when you combine alcohol with risky behavior that you can get unpredictable behavior. And this is often very common in ski resorts and is a major source of ski injuries. So when we look at the specific type of mechanisms, and these are often involuntary, and particularly when you're starting, you can't stop it, well, you very much see the person leaning back on their skis, the ski is off balance, your hips are below your knees, or your uphill ski is unweighted. And these put an increased torque or twist through your knee, which can cause some injuries. So the key issue in terms of avoiding injuries is getting lessons and sticking to your ability level so that you can decrease the risk of twisting your knee if you're in a slope that you're not experienced or able to manage. We also know the unpredictable behavior with drinking, and that can be a huge factor, as I've previously mentioned.
Drop.
And we also realize there's no legislating for stupidity. So you can't prevent those type of injuries, unfortunately. So when you're on the mountain, what can you do? Well, we use the phrase in medicine, primum non nocere, first do no harm. So be careful. Don't try to hurt yourself. Stay in your lane. Don't ski beyond your level of expertise, which is really critical. And oftentimes it's a husband or a boyfriend bringing their partner up on the slope that they're not able for. So do stick to your level of ability, because it's really important. Beware the hazards. When you're on a slope, there's lots of people on the slope, you need to slow down. The uphill skier is responsible for avoiding the downhill skier. So it's really important that you are aware of your surroundings and those people who are surrounding you. And sometimes it's not just on the slopes, it's getting to the bottom of the slopes where injuries can occur. And I think that was more of a head injury rather than a knee injury, but equally someone is going too fast and not being aware of the hazards in their environment. So return to your comfort zone. It's often best when you're starting off, particularly in a week's worth of skiing, that you start easy or get your ski legs, as we refer to it as opposed to going right up to the top of the mountain on the black slopes. So when we're in the clinic, unfortunately, when people injure themselves, they may need to be taken down from the mountain by the ski rescue, and they're often reviewed in one of the ski clinics at the bottom. But when you're in the clinic, as we assess people, we normally aren't doing it on the mountain, that we have the cold light of day, which allows us to assess things more appropriately. So this is an article I really feel is very effective in terms of how to manage someone with a knee. But it was written in 1964 by a gentleman called Professor Apley, and it's referred to intelligent Kneemanship. So I'm going to give you some of the hints and tips that we as surgeons utilize when we're assessing someone who's injured their knee following an injury. So first, we take a history. So to listen is to learn. We all pay lip service to a careful history, but how many of us are patient enough to elicit one? So this is the real key. When you're taking a history, you want to figure out what happened to the person on the slopes. So typically they involve a twisting injury where they may hear a pop, like we saw in the video earlier on. We ask for the patient, or could the individual ski down the mountain? Typically, if you can ski down the mountain, the injury may not be too severe, but if you're taken off the mountain, it likely is. We also want to recognize, did the knee swell up within 12 hours of the injury? And that would give us a good idea that normally if you have swelling, it relates to bleeding. And if you have a knee that's bleeding, it typically indicates an ACL injury or something quite severe within the knee. We perform a clinical examination. So this is really important, you do this appropriately. And this is another quote from this article: to look at only one knee is absurd. Man is biped, and how considerate of nature to provide a normal for comparison. But nature did not provide trousers, and these must be removed. So you often come to a clinic, and I insist the patients wear shorts so I can see both legs, so we can compare the good side with the bad side. It makes for a much more accurate clinical examination. We then have to recognize the surface anatomy around the knee. So we go in a systematic approach to assess the ligaments at the side of the knee and also the ligaments in the middle of the knee through our clinical examination. You can see very clearly, looking at this lady's knee, that she has an injury to the right knee, which is extremely swollen. But if you look more carefully, you'll see that she also had a previous injury to the left knee. But this is typically what you see following a knee injury. You see a big swollen knee, which is difficult to bend and quite stiff. In terms of further investigations, when someone comes to the clinic, we would always get an x-ray, or most times get an x-ray. And the x-rays can be very helpful. I'm going to show you on this x-ray where you see there's a little flake of bone just on the outside of the knee, which indicates that that person has torn their ACL. More commonly, however, we get MRI scans, and these are hugely important in terms of looking for knee injuries. We see this area of whiteness within the bone, and this indicates a bone bruise. So there's two areas of bone bruising, one on the femur here in the middle, and another one at the back on the outside. So if you imagine at the time of that injury, this part of the bone in the femur was in touch with that part of the bone on the tibia. So for that to happen, something has to give, and that's typically the ACL. You can use ultrasound, however, with the advent of MRI, it's not as effective, and it's best for superficial injuries. But the most important thing is to get a referral once you suspect having a knee injury, to get a referral to an orthopedic surgeon or a sports medicine physician who can assess your knee and determine whether you require any further treatment, and at least come to a diagnosis, which is very important. So in the cold light of day, that's the time that we should manage these injuries. I've often heard stories of people getting operations the following day following a knee injury and having a knee reconstruction, and it's not really best advisable. I think you're best off returning to your country of origin, having things assessed, and dealing with the injury in the cold light of day with all the information available. So early diagnosis is important, but often delayed treatment is necessary. And the reason we do this is that the knee may not be ready for surgery following an acute injury. And the reason for that is it does become swollen. It's not a good environment to operate on a knee that doesn't move fully. So it's really important we get people's legs moving immediately after the injury to ensure that we can operate on it when it is appropriate. We also look at non-operative versus operative intervention. I'll give you some case examples later on to define when we would treat something non-operatively versus when we require an operation. And not all knee injuries require operations. That's really important. We try to remove splints as soon as possible to get motion. So the only reason we would leave a splint on is if we're very concerned that a ligament is lax and therefore is going to not heal in the right position. But typically we take the splints that keep the legs straight off so we can get the knee moving as soon as we can. As I said, range of motion is critical. Weight bearing as tolerated is important. So a lot of times people try to offload their knee by not putting the weight through the knee, but weight bearing is very important to load the cartilage, and it allows the cartilage to be nourished, but also improves your range of motion. And where appropriate, and in most cases it is appropriate, we encourage patients to start weight bearing again. So I'm going to go through some common scenarios that I would see in my clinic on a regular basis, and hopefully these will be helpful for you to understand the common knee injuries. So I saw a novice snowboarder. So this is the letter I received. Dear Brian, thank you for seeing Ben, age 14 years, with a snowboarding injury 1 week ago. The mechanism of injury was unclear, so he didn't appreciate what happened. But there was swelling within 12 hours, and he was able to toe touch weight bearing on his toes only. So he's obviously very sore. He couldn't fully extend his knee, so couldn't straighten it out. And he had an X-ray, which was unremarkable, showed a little bit of fluid. An MRI was performed and revealed a small medial condyle fracture. So that's a small fracture at the outside of his knee with the grade 2 MCL, which is the medial ligament or the ligament on the inside of the knee. So he's currently in a brace, and I've advised him to be non-weight bearing. And so the mother will bring on the images. So this is a very common injury. So it's a contact injury while turning. There was no pop. When I took his history, he didn't hear or feel anything pop. He fell to the ground, but he couldn't weight bear, had to be taken off the hill, no immediate swelling, but swelling within 12 hours, which is very common. So when I looked at this young man, I saw his knee was flexed. He had a limp. He had swelling within his knee. He couldn't fully straighten his knee, but he could bend it pretty well. And he had a laxity, or his medial ligament was somewhat loose. But he had a negative Lachman. That's the test we use to assess for an ACL. So that wasn't, I wasn't concerned about that. When we look at his X-ray, you see he's a young man. So these areas are his growth plates, but there was no evidence of any significant injury within his knee on X-ray. We then looked at his MRI, and you can see in the MRI, there's increased signals. So that's increased fluid on the inside of the knee. So this indicates that he had a medial collateral ligament injury. So for this young man, he doesn't require any surgical intervention. We need to get his knee moving, and we need to allow that ligament to heal. And thankfully, he avoided any surgery and was able to return to snowboarding the following season. This is just an example of his ACL being intact, and it's this nice ribbon-like structure going from the tibia all the way to the femur. So that was absolutely fine. So our second scenario is an experienced skier. So the history of this individual is he had a high-speed fall while turning on a steep slope. He heard a loud pop, just like the guy in the video at the start. He couldn't stand, his knee buckled, and he had to be taken off the mountain with immediate swelling. So on examination, his knee was bent, unable to weight bear, a big effusion or lots of fluid within his knee, and he had lots of bleeding or bruising on the inside of his knee. So when I examined him, his knee was opening up hugely on the inside. So he had a big medial sided or inside knee injury, and the Lachman test, his ACL, was positive. So looking at this guy's x-rays, he doesn't show any significant injury on x-ray on the left, which was the uninjured side. But you look on the right, he has this flake of bone on the right side, which indicates that he has torn his ACL. So we look at his MRI scan. First of all, you see the whiteness within the knee. So this is his femur here. This is the tibia. And you see all this fluid within his knee, which indicates he has bleeding within his knee. And if you look at this structure here, which looks a bit like a bow tie, that's his meniscus. So that's sitting off the back of his knee. So that indicates that his tibia is too far forward. So he's torn his ACL. And you can see that here. This is the ACL. So we saw the previous image with a nice ribbon, and you can see that there's no continuity of that structure. So unfortunately, he's torn his ACL. And he also has a big medial sided injury or inside injury, where this should be like a black line, but it's gray, and there's lots of fluid around that area suggestive of a big injury. So unfortunately, this gentleman required an ACL reconstruction and medial collateral ligament reconstruction to get him going again. So the final case is a recreational skier. So the history of this individual is that he had a twisted knee. He twisted his knee trying to remove his boots from the bindings. So we've often seen this scenario where you're tired at the end of a long day and you get lazy and you twist your boot to get out. And he felt a crunch at this time. He used a different form of analgesia, however, to what we recommend. And he said it was fine after a while. So he managed to persevere. But the knee became very painful that night. But he did manage to ski on. He said he lasted the week through gritted teeth. So the examination showed a normal alignment of the knee, but he did have a limp while walking. There was some fluid within the knee, but the range of motion was excellent. However, once I flexed his knee to the maximal extent, he did have some tenderness over the inside, and all the ligaments examination was normal. So we look at this MRI scan here, and we see the inside meniscus or the shock absorber, and this should be like a black triangle like we saw previously, but you see that this white line through the meniscus. And based on this individual's symptoms, they had a lot of displacement of that meniscus and was causing some issue. So unfortunately, they had to undergo an arthroscopy and just remove the torn portion of the meniscus to get them back on the mountain the following season. And this is just a view from the side where you see that that meniscus has flipped and it's stuck down the outside of the tibia here, which causes quite a bit of discomfort. And unfortunately, these type of injuries aren't going to heal with just rest, as you have a displaced fragment, which is the key factor. So thank you very much. I would urge you to be cautious on the slopes and ski within your level of expertise. And if you are injured, however, we're very happy to see you, and we'll hopefully get you back on the slopes as quickly as we can. Okay, thank you very much.
Hi, welcome back, Brian. Thanks for a great talk, and we still have a lot of questions coming in. So a lot of people are asking about braces and taping, you know, some of the meniscus tears or just some way to support the knee. So we'll try and answer them in one question, I think. If you want to talk to us about, someone's mentioned kinesiology tape and various different braces. So just to give your opinion on those, Brian.
Personally, I don't think there has been any studies to show that braces actually reduce the incidence of injury or protect from re-injury following surgery. And certainly I've no experience with kinesio tape, and Andrew might answer that later.
Yeah.
But from my perspective, there is somewhat of a psychological element to it as well. I think it does offer a little bit of feedback for people so they can feel a little more confident and comfortable in a brace. And if it's not doing any harm or restricting your movement, you know, there's no harm in it, but it really, it doesn't have the ability to reduce your injury rate, in my opinion.
Okay, thanks. Andrew?
Yeah, I think that's kind of the key message. It's not the golden bullet, you know, to preventing a knee injury, and I certainly wouldn't be putting all my hope in a knee brace and preventing an injury. You want to be kind of physically ready for skiing, but as Brian said, the psychological impact or the psychological part of it is also, it's also a massive part, you know. So if the patient's happy and it's not doing any harm and they feel it benefits them, then it does benefit them, you know.
Okay, thank you. What's the best way to warm up to prevent a knee injury before going skiing for the day?
Yeah, so I think there's a couple of things in this. The big one is making sure that we're physically ready for skiing. So, you know, doing something the day before isn't going to get us ready for a ski season. But also the same as going for a run or the same as doing a change of direction field sport. We do some form of warm up, and getting the muscles warmed up before going skiing is certainly beneficial. Also then starting on, you know, lower slopes and not going 8 o'clock in the morning straight up to a black slope on the first day back.
Yeah,
it's certainly sensible advice. You know?
okay, good. Someone's asked, does age make you at more at risk for certain injuries?
Yeah, I might take that. I think it does. Yeah, I think if we look at our faces in the mirror as we age, we get gray hairs and wrinkles, and the same thing happens in our joints, and we get a loss of water content, we get more brittle menisci. So if you are, and we also have wear and tear, which occurs with age, that can be exacerbated by skiing. So particularly those kind of twisting motion, which might seem innocuous, and the one I mentioned is someone taking off their boot. We would typically see that in slightly older people in their 40s, 50s. But then someone who has wear and tear or has arthritis and is skiing, they may find at the end of the day in that crouched posture that they will feel more painful. And that's something just to be considered about.
Okay, thank you. Talking as well about the braces and the psychological impact, someone said here, have you any recommendations for addressing psychological barriers upon returning patients to skiing post ACL? Brian, I think that one for you.
I think it's I think we recognize that with all injuries and return to sports, there is a phrase we use, kinesiophobia. So it's a fear of movement. And I think that it takes time for that to occur. And normally people have a little bit of post-traumatic stress or anxiety about going back to a sport that they sustained the injury in. So really it's a case of, you know, taking time to get back into it gradually and make a decision if you want to return to it as well. I think being out with an ACL reconstruction can be quite disruptive to one's life. So I think you have to work with your physiotherapist just to make sure that you're physically able. And then normally when you do the testing, one thing we find with testing is that it gives you that biofeedback that makes you more confident. So people feel, oh, I can't do that. But you say, well, you're just as strong on your injured leg as your good leg. And a lot of times that's very helpful in terms of giving people the confidence to get back.
Okay, thank you. Andrew, patient, he says he's fluid on the knee after overdoing exercise for 2 weeks ago. He's got a skiing holiday coming up in 4 weeks. How can he speed up getting the fluid out of his knee?
Yeah, so I think certainly using some of the methods that we talked about in the earlier talk that I did on the police method, where we're kind of protecting it, so we're resting from aggravating factors. We're using optimal loading, so our optimal loading would be doing our rehab, doing our quad activation work and doing our gluteal work. And then the other side of it is kind of our ice compression and elevation to try and reduce the fluid. But the second arm, I suppose, to that we can also use, and Brian might have more thoughts on this, is anti-inflammatories or medication to assist with that.
Okay.
Yeah, I think that's excellent advice. And then, you know, from our perspective, we often, if you consider the fluid in your knee is like smoke, we want to find the fire. We want to figure out why you have fluid in your knee. Now that can be as innocuous as a little twist or a bit of what we call synovitis or inflammation, or it could be a meniscal tear or something more serious. So, you know, what I would certainly recommend is taking some anti-inflammatories for a period of time, provided you know contraindications, and just see how that fluid settles. A lot of times, if it's just something innocuous, it will settle reasonably quickly. But if it's persistent or it's recurring or you're giving pain in the joint line, I think then you probably need to have further investigations just to see what the source of the fluid is or where the fire is, essentially.
Okay. Brian, does snowboarding, is it considered to be any safer than skiing?
It is for your knees, but maybe not for your shoulders or wrists. So
right. Yeah.
each sport carries with it, type of ski pursuit carries more risk in different joints. And I think aside from having a cold backside on the snowboard all the time, you're more at risk of injuring your wrists or your shoulders because you tend to fall into the slope, whereas skis and your knees are kept together, whereas skis, your knees are apart. So there's more at risk of rotational injuries.
Okay, thanks. Andrew, I have degenerative osteoarthritis in both knees. During skiing, I wear a knee brace and take any anti-inflammatories. Avid cyclist, so fitness and core is good. Is there anything else I can do to combat post-skiing pain and stiffness?
Yeah, so I think a lot of that comes down to, perhaps every sport carries different strains and different stresses on the body, and skiing is quite unique in that it's kind of classed as an extreme sport, and we can be quite fit from a, maybe a GA point of view, a rugby point of view, or a cyclist, but do a couple of days on the slopes and we're pretty wrecked after it, So I think it just comes down a lot to that conditioning point of view, and a lot of that is centered around the quads and perhaps aerobic fitness as well.
Okay, thanks. Brian, someone here, they've just come back from a skiing holiday, they're 54, they do need 2 knee replacements, they're considering getting them done this year as they really want to ski again. Is this achievable, or am I too young to get my knees replaced? I have been told they're bone on bone.
Yeah, I think, from a knee replacement perspective, we take in each individual as they come in terms of what symptoms they're getting. I think the fact that someone's able to ski is a very good sign in terms of their level of function. One of the real indication for someone who we would do a knee replacement on is how much it's affecting their quality of life, and do they have pain at night? That really is the key factor for me. So if it's affecting your quality of life greatly, and then you maybe require a knee replacement even at a relatively young age, at 54. But if you're functioning very well, knee replacement is not without risk as well, and we find that younger patients don't always do as well as older patients, and so that has to be taken into consideration. So I would certainly advise this person to have a consultation with their surgeon, look at the risks of surgery, weigh up their expectations of what they want to do, because you're not guaranteed to get back to skiing, but there's certainly a good chance you would. But you want to do it at the right time, and that's the key with any knee replacement surgery.
Okay, thanks. Another question, Andrew. On average, how many weeks pre-operation physio is required?
Yeah, that's an interesting one. So a lot of things that come down to this is kind of objective testing and how the patient is performing themselves. So rather than a definite timeline of you need 6 weeks, it's more so how long does it take to get what we call a quiet knee, where we can maintain full extension, getting the knee fully straight, maintain a knee bend the same as the other side, and have good quad muscle activation in that we can lift our leg, straighten that leg straight up off the bed. And we can tick all those along with walking normally, that we have no limp. I think that's a suitable time then that we can suggest they can go in for surgery.
Okay, thank you. One here, I've had an ACL reconstruction, several cartilage tears from soccer and rugby. During skiing this season, struggling with a lot of swelling, Baker's cyst, painful, age 62. How do I know when it's time to think about knee replacements?
Well, I think it's similar to the last question. I think when it affects your quality of life. So it's, yes, you'd expect someone who's skiing that, more loads going through their knee, they may have more swelling, but it's in their day-to-day activities. Remember, we only ski at best a couple of weeks a year or more if you're lucky. So it's more in your day-to-day, how much it's affecting you. And particularly with night pain, as I mentioned, and then having an assessment with someone who's going to do some weight bearing x-rays to see how bad the arthritis is, and they'll be able to give you advice on that.
Okay, Andrew, would those rehab exercises be beneficial for a patella injury?
So I suppose we need to be a bit more specific in the injury. So there's a couple of patella-based injuries. It could be a patella fracture, it could be a patella dislocation. I suppose the key to those injuries is their general exercises for the injuries that we talked about in skiing, which were predominantly ACL, MCL, and meniscal injuries. But if we want to tailor them to a patient outside of those arm of injuries, it'd be pretty important just to get a tailored program by a physiotherapist on that, because it's very hard to give general advice on an injury when we haven't assessed them.
Yeah, lovely, thank you. Someone's saying, we've spoken about when to go back after an ACL surgery, but they're saying if they don't opt for surgery and it's non-operative ACL management, how long then should they return to skiing?
Yeah, again, that's an interesting one again, and it comes back to how is the patient doing themselves. So if a patient was going back to skiing and they were a conservatively managed ACL, which we see a lot of in here, again, I would advise to do the testing so that we have some measures on their quad strength, some measures on their hamstring strength, have a look at their jumping and landing to see are they going to be able to tolerate the forces of skiing.
Okay.
And if they can tolerate those forces, there would be no problem with skiing.
Yeah. Okay.
Yeah, I'd also add to that, I think it's important that you check the symptoms and whether someone feels unstable. I think that, if you might be fine in a straight line, but then if someone twists, that can cause a sense of instability to the knee. So I think you'd want to be symptom free from an instability perspective as well.
Okay. So there's one here, dislocated knee 18 months ago, since had patella stabilization surgery with 10 months recovery, returned to playing Gaelic football at the start of the season in 2022 without any recurring injuries. What precautions should I take for skiing, i.e. wearing supports, etc.?
Yeah, that person seems to have done very, very well following surgery, which is successful, and be able to return to sport. So if they have a good level of fitness and they, good gluteal and quad strength, I would think that they should be able to return to skiing. And I wouldn't advise any precautions if they're fit and healthy.
Okay. Someone just said, do you see an increase in ACLs in females compared to the males? From
skiing or from other sports? Yeah, we certainly have seen an increase in female patients, and I think it's been a big epidemic in Australia where I was recently working, and there was a huge increase as more women were playing ladies AFL, so yeah, we see it a lot, and we see it in younger patients as well, quite a lot. With skiing, it's like a conveyor belt for ACL injuries, whatever the gender. So it's a very a common injury, unfortunately, both genders.
Andrew, what is the importance of flexibility in comparison to strength training for rehab for skiing?
Yeah, so I suppose kind of the two of them go hand in hand. The stronger we are in our muscles, the more range or the more flexibility we tend to have. So both of those kind of go hand in hand. I wouldn't pick one over the other. I certainly wouldn't work on a stretching program when strengthening is what we want. Strength would outweigh the flexibility arm for knee injuries and skiing anyway.
Okay, lovely. I think that's it, guys. Thanks so much for joining us tonight, and thanks everyone else for joining us. So we have our next talk is on the 21st of March, and that's Fitness for Life, and that's golf related, but you can also join in if you've any other issues with Fitness for Life that really pertains to all sports. We will be sending a survey out, and as I said, all these talks are on our website, so you can go in and have a look at them afterwards, or direct other people if they're interested to them as well. Thanks very much for joining us.